Midoro.
Good morning, lecturer. I am Amadrijo Dalibu. I'm presenting a case presentation from Moyo General Hospital, maternity ward. I'm presenting on a female patient. Her biodata, her name is MS. She's 31 years old. She lives in Vuropi village, Opi parish in Moyo district. She's a Catholic by religion. Tribe is Madi. Occupation or employment, a businesswoman selling tomatoes in the market. Her next of kin is KR, her husband. Insurance detail, she doesn't have. Date of admission, 16th of June 2026. Presenting complaint. The patient presented with low abdominal pain and vaginal discharge for 3 days. The onset of the pain started suddenly 3 days prior to admission. The pain is located in the low abdomen, suprapubic region. The pain has been continuous for the last 3 days. The pain is described as sharp and cramping in nature. The pain worsens with movement or during urination. The pain is slightly relieved by rest and taking over-the-counter painkiller. And she said she has been taking Panadols for the last 3 days. The pain is persistent throughout the day but becomes worse at night. The patient is rated at 7/10 on the pain scale. History of presenting complaint. The patient was apparently well until 3 days prior to admission when she developed low abdominal pain. Pain started gradually and was initially mild but progressively increased in intensity, prompting her to seek medical attention. The pain is localized in the lower abdomen and does not radiate. It is described as cramping in nature and has been persistent over the past 3 days. The patient reports that the pain worsens with movement and physical activities, but slightly relieved by rest. The pain is associated with general body weakness and mild fever, but there is no history of vomiting, diarrhea, or abdominal distension. She denies any history of trauma. She initially took over-the-counter painkiller from a nearby drug shop, which provided temporary relief, but the pain recurred and became more severe. Due to persistent and worsening symptoms, she presented to the hospital on 16th of June 2026 for further evaluation and management. Review of system. General health state. The patient reports general body weakness and mild fever, no significant weight loss or loss of appetite. Integumentary system. There is no skin rash, itching, wound, or discoloration noted. No visual disturbance, no ear discharge or pain, no nasal congestion, no oral sore, no neck swelling or stiffness, and no breast pain or discharge. Central nervous system. No history of dizziness, fainting, seizure, or loss of consciousness. Cardiovascular system, no chest pain, palpitation, or swelling of the limbs. Respiratory system, there is no cough, shortness of breath, or chest tightness. Gastrointestinal system, patient reports low abdominal pain, no nausea, vomiting, diarrhea, or constipation. Urinary system. There is no pain during urination, no frequency, urgency, or blood in the urine. Genitalia. There is no abnormal vaginal bleeding, vaginal discharge, itching. Musculoskeletal system, no joint pain, muscle pain, or difficulty in moving apart from discomfort during abdominal pain. Endocrine system, there is no history of excessive thirst, excessive urination, or heat, stroke, cold intolerance. Past medical history, the patient reports no known history of chronic illness such as hypertension, diabetic mellitus, chronic illness such as asthma. She has not been previously admitted for any major medical condition. There is no history of tuberculosis, HIV, AIDS, or any other significant infectious disease. She denies any history of similar episode of low abdominal pain in the past. She is not on any long-term medication and has no known allergies. Past surgical history, the patient reports no history of any previous surgical procedure. She has never undergone any operation and has no history of hospitalization for surgical condition. Past family history, the patient reports that both parents are alive and generally in good health. There is no known family history or chronic illnesses such as hypertension, diabetes, asthma, or sickle cell disease. She has 4 siblings, all who are alive and well with no known chronic medical condition. There is no history of hereditary diseases, mental illness, or similar gynecological condition within the family. Gynecological and obstetric history. The patient may attain menarche at the age of 13 with regular menstrual cycle occurring every 28 to 30 days and lasting 4 to 5 days. She reports moderate flow without severe dysmenorrhea prior to this illness. She is gravida 2, para 2, with both deliveries being spontaneous vaginal deliveries at term without complications. The last childbirth was 3 years ago. She is not currently pregnant and denies any history of infertility, miscarriage, and stillbirth. There is no history of sexual transmitted disease, although she reports having experienced occasional vaginal discharge in the past, which resolved without medical intervention. She is not on any family planning method currently. Psychiatric history. The patient has no history of diagnosed mental illness such as depression, anxiety disorder, psychosis, or bipolar disorder. She has never been admitted to a psychiatric facility and is not on any psychiatric medication. She denies any history of suicidal thought, hallucinations, and abnormal behaviors. Her mood is reported as generally stable prior to the current illness. Social history. The patient's social support system includes her partner and extended family members who assist when need be. There is no history of domestic violence or significant social stressors reported. She has access to nearby health service and seeking medical care when necessary. Physical examination. Part A. General appearance. No jaundice noted. Sclera not yellow. No signs of anemia such as pallor of conjunctiva or nail beds. No cyanosis observed on the lips or fingertips. No finger clubbing noted. There is no peripheral edema observed. Mucous membrane slightly dry, but no oral lesions. There is no palpable enlarged lymph node. There is mild dehydration suggested by slight dry mucous membrane. The patient appears ill-looking, in mild painful distress, and is lying still due to low abdominal discomfort. She is alert, oriented to time, place, and person. Part B. Vital signs. Temperature was taken 38.1 degrees centigrade. That's with mild fever. Pulse rate is 96 beats per minute, regular, slightly tachycardia. Blood pressure was 110/70 mm of mercury within normal range. Respiratory rate 20 breaths per minute, which is normal. SpO 2 97% on room air. Pain score rated at 7/10. System by system examination. Abdomen. On inspection, the abdomen is flat, moves with respiration. No visible masses or scars observed. On palpation, there is tenderness noted in the suprapubic region. No rebound tenderness or guarding. No palpable mass felt. On percussion, there is resonate throughout abdomen, mild suprapubic dullness. On occultation, normal bowel sound present. Cardiovascular system, no inspection. On inspection, no visual precordial bulge or pulsation seen. On palpation, apex beat at fifth intercostal space, mid-clavicle line. Auscultation, normal heart sound, S1 and S2, no murmur or added sounds. Respiratory system. On inspection, there is normal chest expansion, no use of accessory muscle. On palpation, equal chest expansion bilaterally. On percussion, resonant lung fills. On auscultation, clear breath sounds bilaterally, no wheezing or crepitations. Central nervous system, patient is alert and oriented by passion, time and place. No signs of neurological defect. Normal speech and coordination. Genital system, where appropriate clinical assessment is done. Patient reports vaginal discharge, no external genital lesions observed. Further spectral examination recommended for detailed assessment. Musculoskeletal system, normal range of movement, no joint swelling or deformities. Movement slightly limited due to abdominal pain. The summary of physical finding: the patient is 31 years old, female, in a mild painful distress with fever of 38.1 degrees centigrade and suprapubic tenderness. Vital signs are generally stable except for the mild tachycardia and fever. Physical examination is significant for low abdominal tenderness and report vaginal discharge, suggestive of possible pelvic infection. Other systems are largely normal. Laboratory investigations and finding: full blood count was done and the result was white blood cells is elevated, for example 14.500 per millimeter. Is suggestive of infection and inflammation. Hemoglobin Hb is 12.5 mg per deciliter, which is within normal range. Urinalysis shows mild leukemia present. Interpretation is possible urinary tract involvement and contamination. Pregnancy test: HCG source negative on ruling out pregnancy. Vaginal swab culture pending or source bacterial growth, suggestive of reproductive tract infection. C-reactive protein elevated, indicates active inflammation, stroke infection. Nursing diagnosis: provisional or confirmed. Acute pain related to pelvic inflammatory process as evidenced by suprapubic pain rated at 7/10. Hyperthermia related to infectious process as evidenced by elevated temperature of 38.1 degrees centigrade. Risks of infection spread related to ascending genital tract infection. Impaired comfort related to low abdominal pain and vaginal discharge. Anxiety related to illness condition and hospitalization. Deficient knowledge related to process treatment and prevention of reinfection. And we have risk of fluid balance risk of fluid imbalance related to fever or reduced oral intake. Nursing care plan. Assessment: patient reports low abdominal pain rated 7/10, guarding behavior, suprapubic tenderness on palpation. Nursing diagnosis: acute pain related to inflammation process (PID) as evidenced by suprapubic pain and guarding. Goal/objectives: patient will report reduced pain of less than 3/10 within 48 to 72 hours. Patient will demonstrate comfort and improve mobility. Interventions: assess pain severity, location, and characteristics regularly. Administer prescribed analgesics and antibiotics as ordered. Encourage rest in comfortable position, for example, semifurlers. Apply warmth compression to lower abdomen if prescribed. Provide emotional support and reassurance. Evaluation and follow-up. Pain score reduced to acceptable level, that's less than 3/10. Patient appears more comfortable and able to move with minimal discomfort. Assessment 2. Elevated temperature of 38.1 degrees centigrade, chills, and elevated WBC. That's a diagnosis. Hyperthermia related to infectious process. Goals and objectives: patient will maintain normal body temperature of 36.5 to 37.5 degrees centigrade within 48 hours. Intervention: monitor temperature 4 hourly, administer prescribed antipyretics, encourage increased oral fluid intake, promote tepid sponging if fever persists. Administer antibiotics as prescribed. Evaluation and follow-up: temperature maintained within normal range. Patient shows no signs of fever or chills. Assessment 3. Patient reports vaginal discharge and laboratory findings suggest infection. Nurse's diagnosis: risk for infection spread related to ascending reproductive tract infection. Goal and objectives: patient will show no signs of worsening infection. Interventions: maintain strict aseptic technique during care, administer prescribed antibiotic correctly, educate patient on perineal hygiene, front to back wiping, encourage completion of full treatment course. Evaluation and follow-up: no worsening of symptom, infection control as evidenced by improved clinical signs and lab results. Assessment 4. Patient expressed discomfort, mild anxiety due to illnesses and hospitalization. Nursing diagnosis: anxiety related to illness, condition, and hospitalization. Goal and objective: patient will verbalize reduced anxiety and demonstrate understanding of the condition. Intervention: provide clear explanation of disease and treatment. Pain: offer psychological support and reassurance. Encourage family support. Visits or, if appropriate, allow patient to ask questions freely. Evaluation and follow-up: patient appears calm and reassured. demonstrates understanding of condition. Assessment 5. Patient has limited knowledge about condition and prevention of reoccurrence. Nurse's diagnosis. Deficient knowledge related to disease process and prevention. Goals and objective. Patient will verbalize understanding of PID treatment and prevention strategies. Interventions. Educate on causes of transmission and complications of PID. Teach importance of completing antibiotics. Advise on safe sexual practice and partner treatment. Provide written and verbal health education. Evaluation and follow-up. Patient correctly explains conditions and prevention method. Demonstrates adherence to treatment plan. What was done better and what can be done to improve medical and nursing management of this patient condition. Part A. What was done better? Good practice observation. Early health-seeking behavior. The patient reported to the hospital with 3 days of symptoms onset, allowing relatively early interventions before severe complications developed. Prompt clinical assessment, a full history, physical examination, and relevant laboratory investigations like FBC, urinalysis, pregnancy test, CRP, and vaginal swab were appropriately initiated. Accurate provisional diagnosis. The clinical team considered pelvic inflammatory disease early based on presenting symptoms and examination findings. Timely initiation of treatment. Empirical antibiotics and analgesics were started without delay to control infection and pain. Pain management. The patient's pain was assessed and managed using appropriate pain relief measures, improving comfort. Health education provided. The patient received initial education on hygiene, medication adherence, and follow-up care. Nursing monitoring. Vital signs, especially temperature and pain score, were regularly monitored, ensuring early detection of improvement or deterioration. Part B. What can be improved? Areas of strengthening care. Strengthen early STI screening and partner management. Sexual partners should be traced, screened, and treated spontaneously to prevent infection and further transmission. Enhance patient education. More detailed counseling is needed on safe sexual practice, use of condom, importance of completing full antibiotic course, and risk of untreated PID such as infertility and ectopic pregnancies. Improve the infection prevention and control, IPC. Strict adherence to septic technique during all pelvic examination and procedures should be emphasized to prevent cross-infection. Follow-up system. A structured follow-up appointment should be clearly arranged to monitor response to treatment and prevent complications. Psychosocial support. Great attention should be given to emotional and psychological support, as reproductive tract infection may cause anxiety and stigma. Documentation and continuity of care. More detailed documentation of vaginal discharge characteristics, pelvic examination findings, and treatment response would improve continuity of care. Community health education. Outreach programs should be strengthened to educate women on early signs of reproductive tract infection and when to seek care. Thank you for listening. I beg to submit. Thank you.